Hello, my friends. It's Dr. Sharon with Clinic Reviews. I'm back to do 5 more NCLEX style questions, and I'm excited today because I am going to be teaching you a really important prioritization strategy. This is a strategy that you probably should expect to get between 3 to 5 questions on the NCLEX. So let's go ahead and get started. So the first question: the RN is caring for a client with major depression. Which of the following statements by the client is most concerning? I've been sleeping 12 to 14 hours every day. I've lost 10 pounds since I started feeling so bad. I have started losing my hair. I just don't enjoy doing anything anymore. All right, so let me teach you how to read this question. Here's the thing. You have one patient and you have 4 different symptoms of that one patient. Listen, if you're keeping notes or if you're like, how do I differentiate between different prioritization strategies? Here's what you write down. One patient, 4 different symptoms, and you have to say which one you are most concerned about. It doesn't always say most concerned. Sometimes it says which is your highest priority, which you're going to report to the healthcare provider. Which is most important. But the key is you have one patient with 4 different symptoms. You don't have 4 patients and you're trying to decide between 4 patients. That is not what it's asking you. It's saying one patient, 4 symptoms.
Before I go on holiday, I always wrap my passport in foil and my cards in foil. If you didn't know, there's people going around stealing your identity and your money. It's so easy for them. They're walking around with card readers and they're tapping your pockets or your bags.
The other thing it's not doing is not telling you the 4 symptoms and then asking you which order you would implement first. There's another type of NCLEX question that says you have a patient with these symptoms, and the symptoms are in the question. They're not in the answers. The symptoms are in the question. And they tell you the symptoms, and then they say, which order would you implement first? That's a completely different type of question. I'll do those some other time, okay? But these, you have one patient, and then it says, which assessment finding are you most concerned about? Which statement are you most concerned about? And the assessment findings or the statements are in the answers, not in the question. So the way you read this is you say, all right, and they have one patient, and they always tell you what the diagnosis is. They could say schizophrenia, they could say major depression, they could say heart failure, they could say diabetes. It wouldn't matter. One patient with certain diagnosis, and then which symptoms are you most concerned about? When they do that, what you're saying is which symptom is unexpected. Did you get that? Which symptom is unexpected? That's the one you're most concerned about. So what you should know is that 3 of these symptoms should be expected for a patient with major depression. One of them isn't expected for a patient with major depression. I'm most concerned about the one that's unexpected for a patient with major depression. All right, let's look at these answers again, and maybe it'll be more obvious. I've been sleeping 12 to 14 hours every day. Well, we know sleep disturbances is common for people with major depression. Either they sleep less or they sleep more. This looks like they're sleeping more, so I say, well, that's expected with major depression. I've lost 10 pounds since I started feeling so bad. Well, we know eating disturbances are common for people with major depression. Either they eat more or they eat less. Typically, they eat less. Anorexia is very commonly associated with major depression. So if they're eating less, they could lose weight. So I go, well, that seems to be expected if they're eating less. I'm not that concerned about that. But you know what? Let me keep it on the list just in case there's nothing else that would be more concerning. Because maybe, right? Maybe. 3, I've started losing my hair. I've started losing my hair. I can't think of any symptom associated with major depression where they would start losing their hair. I can't think of any reason at all that they would start losing their hair. So I got to keep that on my list. That's like not expected. I just don't enjoy doing anything anymore. Okay, that's expected. That's expected. And don't say, well, if they don't enjoy doing anything more, they could be suicidal. You're right, they could be, but it doesn't say that, does it? And you only know what they tell you. So I expect them to not enjoy doing anything anymore. They're depressed. That's what depression is. Okay? It's depressed mood. All right. So I have to choose between 2 and 3. I've lost 10 pounds or I've started losing my hair. I can rationalize very easily why 2 is expected because I know they have appetite disturbances. So I am going to pick 3. I've started losing my hair. And that is the correct answer because that is the one that is unexpected. All right, next question. The RN is caring for a client with generalized anxiety disorder who recently started taking lorazepam. Which of the following statements by the client is most concerning? So we have a patient with a known disorder. They have generalized anxiety disorder, and they say they recently started taking lorazepam. Now, if you don't know what lorazepam is, it's a benzodiazepine. The drugs that end in PAM and LAM, LAM, PAM, and LAM are benzodiazepine, so it's a minor tranquilizer. And so they've started taking a minor tranquilizer to help with the generalized anxiety disorder. Which of the following statements by the client is most concerning? So I immediately say to myself, I have one patient with a known problem, which is generalized anxiety disorder, who's also taking lorazepam. I got to keep that in my head. And they want to know which statement is most concerning. So I'm going to say, well, the statement that's unexpected is most concerning. So let's read the statements. I've been so sleepy lately, I can barely stay awake at work. My mouth is so dry, I have to keep water bottle with me all the time. I've started to eat an apple every day to help prevent constipation. My hands have been tremoring so much it is hard to sign my name. Okay, well, generalized anxiety disorder, but they've started taking lorazepam, which is a minor tranquilizer. And I know minor tranquilizers have anticholinergic side effects. I've done a different video on psych drugs. And so you might want to watch that where I talk about side effects, psych drugs and side effects, I think is what it's called. So I know that dry mouth, blurred vision, bladder retention, constipation, and drowsiness are side effects of psych drugs. So I'm keeping that in mind, right? All right, I've been so sleepy lately I can barely stay awake at work. Well, this is a minor tranquilizer, so that's kind of expected, actually. Now, I may need to do some teaching about it to, like maybe you shouldn't take it right before you go to work, but we may need to do some teaching about it, but that doesn't concern me. My mouth is so dry, I have to keep water bottle with me all the time. Well, that's expected. That's an anticholinergic side effect. They're taking a psych drug. I know psych drugs have anticholinergic side effects, so I'm not worried about that. I've started to eat an apple every day to help prevent constipation. Well, that's fine. Constipation is an expected side effect of psych drugs, so that sounds okay to me. My hands have been tremoring so much it is hard to sign my name. So you might say, well, that's expected if they have generalized anxiety disorder. Well, not really. If they were having a panic attack, I would maybe expect some hand tremoring, maybe severe anxiety, but not generalized anxiety disorder, and particularly not after starting lorazepam, a minor tranquilizer. So this is unexpected. And, when I look at something like that, I go, that just doesn't seem right to me. I can understand why they'd be sleepy. I can understand why their mouth would be dry. I can understand why they'd be constipated, but it just doesn't make any sense to me why their hands are tremoring. So if I'm going to pick the unexpected finding, I have to pick 4. I have to. And you could probably sit here and rationalize with me why one of the others is right, but what I'm teaching you is how to read questions on the NCLEX. I am teaching you how to read them because it's not just about what you know, it's about understanding the question and what it's looking for. Okay, next question. You're caring for a client with schizophrenia. After completing their morning assessment, which of the following findings should receive the highest priority? All right, so again, we have one patient with a known diagnosis, and we say, all right, you're going to find the following, assessment data, and which one do you care is most worrisome, highest priority, whatever. And so I'm saying to myself, I'm looking for the unexpected finding. Unexpected. Client has crackles in the right posterior lung base. Well, that's not expected with schizophrenia. All right, next one. Client refuses to take a shower in the morning. Well, that's actually expected with schizophrenia. It's part of the negative symptoms associated with schizophrenia. Schizophrenia has positive and negative symptoms. Positive symptoms are things like hallucinations, delusions. It's psychosis. So positive symptoms are the things that the symptoms they have that you wouldn't expect, right? So they have new symptoms or they put, I kind of add like adding it, right? Positive symptoms, think of a plus sign, plus, that's a plus sign. Think of it as a plus sign. Their symptoms they're adding on. And then they have negative symptoms. These are things you're taking away. So negative symptoms are things they're not doing that you would expect them to do. And positive symptoms are things you don't expect them to have, but they're doing. So negative symptoms for schizophrenia are things like not bathing, not eating, not interacting with other people, whereas positive symptoms are things like psychosis, delusions, hallucinations, hearing voices, and so forth. So I go, well, they're refusing to take a shower. That's actually expected with schizophrenia. 3, client exhibits a narrow ideas of reference. Ideas of reference are a type of delusion, which is expected with schizophrenia. Client states he's hearing voices. A hallucination, again, it's expected with schizophrenia. So I have to pick number 1 because that's the only one that's not expected. And you could say, well, if they're hearing voices, that's a problem. Well, it's a problem, but it's expected problem, right? That's why they're here. That's why we're taking care of them, because we would expect them to hear voices. We expect to have them have ideas of reference and refusing to take a shower. These are the positive, 2, 3, and 4 are positive and negative symptoms that I expect with schizophrenia. 1, I don't expect at all. Okay, I don't expect it at all. So I'm going to have to pick number 1, and that is the correct answer.
Cole, he's my miracle child. So how does your miracle child get cancer? How does that happen?
There was a mass, basically a tennis ball-sized tumor at the base of his brain. We were then rushed over to our local children's hospital, and that's when they told us that he had cancer. Couldn't believe that something that big was inside his little head. And everybody always says the worst sentence in the world is you have cancer, and it's not. The worst sentence in the world is your child has cancer. Our oncologist reached out to St. Jude.
St. Jude knew exactly what was happening. They already had a clinical trial going on.
All right, next question. Now, I decided to move into non-psych stuff just to show you that this applies also in non-psych questions. It's the same strategy, but non-psych issues. So you're caring for a client with type 2 diabetes, which of the following lab values is of most concern. So I say, I have type 2 diabetes. I'm looking for the lab value that is unexpected with type 2 diabetes. Morning serum glucose of 154. Little high, but that's expected with type 2 diabetes. Glycosylated hemoglobin is 7.6. Little high, but that's expected with type 2 diabetes. Serum potassium is 4.9. That's actually high normal. Normal potassium is 3.5 to 5.0, so you got to know normal values. Make sure you know those. Serum creatinine is 2.1. A little high, but not expected in type 2 diabetes. Not expected to have a elevated serum creatinine. That actually indicates that they're having some kidney damage associated with their type 2 diabetes, and I don't like that. I don't like that at all. That's unexpected. That's a problem. So I'm going to have to be most concerned about the serum creatinine of 2.1. Now, I want you to remember, this is something that Mark talked about when he talked about in his video on strategies for passing NCLEX or how to pass NCLEX. He talked about how you don't memorize answers from question data banks or question banks because the answer is only right because of the other answers, right? So you can't say to yourself, do not say to yourself, well, I got to memorize that a serum creatinine of 2.1 is always my greatest concern. If you say that, that's wrong. Serum creatinine of 2.1 is not always your greatest concern. In fact, I would go so far as to say is a serum creatinine of 2.1 is not usually your greatest concern, but it's the question and the other answers, right? So the fact that the other answers are expected makes 4 your greatest concern. It makes a creatinine of 2.1 your greatest concern because 2.1 is the only unexpected finding. And you also look at the context of the question. We have type 2 diabetes. If they said your patient has an acute kidney failure, which of the following is your greatest concern? Well, if they have acute kidney failure, serum creatinine of 2.1 is expected. I'm not picking that one, right? I'm not picking that one. So you've got to understand that the correct answer is based on the context of the question and the other answers. So you have to learn how to read the question and know what you're conceptually what you're looking for. I'm looking for the unexpected symptom. I'm not just looking for a creatinine level. I'm just looking for the unexpected symptom. So the correct answer is 4. All right, last question. Client diagnosed with major depression has sleep and appetite disturbances and a flat affect and is withdrawn. The client's been taking fluvoxamine 50 twice daily for 5 days. Which client behavior is most important to report to the next shift? Okay. Now, I am showing you how this question is completely different than the other 4, because you could read this and go, oh, which behavior is most important? All right. But the context of this question is completely different. Here, they give you the symptoms in the question. Did you notice how in the other questions, they didn't give you any symptoms? All they did was give you a diagnosis. That was it. Here, they give you a diagnosis and symptoms. They say sleep and appetite disturbance, flat affect, and withdrawn. Sleep disturbance, appetite disturbance, flat affect, withdrawn. They've been taking an antidepressant for 5 days. Which behavior is most important to report to the next shift? So when you get a question about reporting to the next shift, you have to look and see what it's either according to the diagnosis. If they give just a diagnosis and no symptoms, then you're kind of like, okay, I'm looking for the unexpected finding. That's what I have to report to the next shift. But when they give you symptoms, you're looking for a change to the normal. So you say, well, they have been having sleep disturbance, appetite disturbance, flat affect, and withdrawn. Since I know these are the 4 things they've been experiencing, what I'm going to report to the next shift is something that changes, a changing assessment. A changing assessment, okay? So something that is changed from sleep disturbance, appetite disturbance, flat affect, and withdrawn. So let's see which is different. Client's flat affect. Well, that's exactly the way it's been. I'm not reporting the same thing. That's no big deal. Client interacting with a visitor. Says it's withdrawn, but it doesn't say that he doesn't interact, but I'm going to keep 2 there as a possibility. Client sleeping from 2300 to 6, so they just slept 7 hours straight. Well, they've been having sleep disturbances, so this seems like a change. If he's been having sleep disturbances and now he's sleeping 7 hours straight, I'm like, that's different. So I'm going to keep 3 on there. Client spending the entire evening in her room. Well, she's withdrawn, so client spending the entire evening in her room is expected. It's a change. It's not a change. It's the same. I'm looking for something that's a change. So is interacting with a visitor more of a change, or is sleeping for 7 hours at night more of a change? Well, it doesn't say she refuses to interact with visitors. It says she's withdrawn, but it doesn't say she refuses to interact with anybody. And it specifically says she has sleep disturbances. So I'm going to have to go with what most closely reflects the data in the question. And clearly they've had sleep disturbances, and so I'm going to have to pick the one that shows they're no longer having a sleep disturbance. I have to pick 3. And 3 is the correct answer. All right, so one of the key things about answering NCLEX questions is understanding the strategies for answering them. What we do in clinic reviews is we focus on these kinds of things. This is not a specific strategy that we teach in clinic reviews, but we teach so many strategies like this: how to read questions, how to interpret questions. So if you want to get more things like this, we strongly recommend you come to a clinic review. You can find them at clinicreviews.com. We have online reviews every month and in-person reviews monthly, almost monthly. So we'd love to see you at one of our reviews, and good luck on your NCLEX. Thanks for watching.
I don't know what to play. That's okay. This is just a random phrase, but it sounds good anyway. No song arrives fully written. No pot begins fully formed. Are you calling me a pot? Kinda. But you're so much more. The sheep, they do not know where they are going, but they're following the shepherd where he leads. The flower does not know how it is growing, but the rain still falls and gives it what it needs. There's a reason for the colors in your story. There's a picture, though you cannot see it yet. Every thread has a purpose, and soon you'll see you're part in this tapestry. And when you feel like nothing is connecting, and you're searching for an answer you can't find, just remember that each strand is intersecting to reveal what the Creator has designed. Any masterpiece is gonna take some time. There's a reason for the colors in your story.
If there's a reason, I can't find it.
Though you cannot see it
Sure,
yet.
I believe
that every thread has a purpose,
but I don't
soon you'll see your part in this tapestry. So lift your eyes above the hills, higher up and higher still. If you could see from heaven's view all the plans drawn out for you, like the way we work the loom, he knit you from inside the womb. Every string is used in his design.
I lift my eyes above the hills, though it's not clear, I know I will catch the view that heaven sees and leap into his plans for me. I'll find out where the story goes. I'm not there yet, but now I know the one who brought this world to life has seen it all before it's time. So ready or not, come what may, I'll face whatever may come my way, 'cause everything is used in his design. There's a reason for the colors in my story.
What truly triggers chronic memory lapses never has to do with age, but rather with something people ignore daily. Hardly anyone knows this, but brain blackout.
Hello, my friends. It's Dr. Sharon with Clinic Reviews. Welcome to the Clinic Review family. This is my Happy Thanksgiving, Merry Christmas, Happy New Year, Happy 4th of July gift to you. I'm doing prioritization strategies. People ask me all the time to do these, and I will be honest, you get a lot of prioritization questions on the NCLEX, so I'm going to be doing this for you today. Today I'm going to be talking about two specific types of prioritization, and then I just want you to know there's another one that we talk about in our Clinic Review. And I would strongly recommend you take a Clinic Review with us if you're getting ready to take the NCLEX. Today I'm going to talk about two different prioritization strategies, one of which I already talked about in another video, and I'm going to just refresh your memory on it here, and we're going to practice it and show how it's different from the other prioritization strategies. So the one that I've already talked about is when you have one patient in the question, and all you know about him is their diagnosis. That's it. You don't know anything else. They just tell you the name of the patient and the diagnosis. The diagnosis could be COPD, heart failure, schizophrenia, ADHD. It doesn't matter. It could be anything. All you know is their diagnosis. And then they say, what findings would you report to the next shift? What findings are you most concerned about? What findings would you call the doctor about? Whatever it is, you always report or call about or are most concerned about the unexpected findings. Okay? And we'll focus on that as we go through questions. The other prioritization strategy is when you also have one patient and you have a diagnosis in the question, but you have more. It's not just a patient, the diagnosis. Now you know all kinds of things about them. You know about their symptoms. So the first one is where you have just the patient and the diagnosis. The second one is you either have the patient, the diagnosis, and the symptoms. And then they say which order would you implement first, or it may say which problem will you address first. And you have to look at all those symptoms in the question. So you have to take a minute to analyze the question. This isn't the kind of question you just automatically know the right answer. You have to take the time to look at all the symptoms, identify which one is the physiological or the objective finding, and you have to address that first. So your top priority is always physiological, which is objective, like measurable, right? You have a number to go along with it, or you have a very objective word that you know that means it's an objective problem. You address that first. If you don't have any objective problems, you address safety issues. If you don't have any safety issues, you address comfort issues. Comfort issues are subjective findings. They're the things the patient reports. I'm hungry, I'm in pain, I'm nauseated, whatever it is, right? Those are the subjective findings. Those are what you address third. And then if you don't have any of those, you can address the psych issue. Maybe they're hallucinating, maybe they're depressed, whatever it is, but you address the objective findings first, physiological, then the safety, then the comfort or subjective, and then the psych issues. Okay, so let's get going, starting to talk about some actual questions. All right, the nurse is evaluating and assessing a patient with a diagnosis of chronic emphysema. The patient is receiving oxygen at a flow rate of 5 mL by nasal cannula, which finding concerns the nurse immediately. Find by basilar crackles, a respiratory rate of 8 breaths per minute, the patient sitting up and leaning over the nightstand, or a large barrel chest. All right, so we look at the question, I say, well, I know I have a patient, I have one patient, and I know their diagnosis, but I don't know anything else. I don't know any symptoms or anything like that. All I know is they have chronic emphysema. And you might say, well, you know they're wearing oxygen. Okay, but that's not a symptom. That just tells me they're wearing oxygen. It doesn't really tell me anything. Okay, so, all right. So emphysema. So now I have to say, well, out of all these symptoms, which one is unexpected for a patient with emphysema? In order to do that, so that I don't let my mind get distracted, I turn this into a series of true-false questions. So here's what I do. I say a patient with emphysema would be expected to have fine bibasilar crackles. Yeah? I mean, maybe they don't all have that, but it's certainly not unexpected, right? Chronic emphysema, they got all kinds of weird lung sounds, including probably wheezes and diminished lung sounds, but it's nothing major, so yeah, I'm okay with that. They'd expect to have fine bibasilar crackles, fine. A patient with emphysema, I would expect to have a respiratory rate of 8 breaths per minute. No. In fact, I'd probably be more likely to think they'd have a respiratory rate of about 20, to be honest, maybe even 24. Chronic emphysema. So I definitely would not expect 8 breaths per minute. That's under normal anyway. So 12 is the low end of normal. So 8's already slow, but I certainly wouldn't expect someone with emphysema to have a slow respiratory rate. So no, I don't expect that. That's unexpected. A patient with chronic emphysema, I would expect them to be sitting up and leaning over the nightstand. Okay, so I want you to picture this. They're sitting up and they're leaning over the nightstand like this. Now, what is this position called? This position is called tripod, whether they're standing up and leaning over or whether they're sitting up and leaning over. It's called tripod position. And this is the position we teach them to use when they feel short of breath. That's what we teach them. So they're doing exactly what we taught them to do. So we should be going, well, sure, I mean, I just taught them to do that, so why wouldn't they be doing it? Helps, helps reduce any dyspnea. They're more comfortable when they're sitting like that. So yeah, I would expect that because I probably just taught them to do that. So yeah, I expect them to be sitting up and leaning over the nightstand. I would expect a patient with chronic emphysema to have a large barrel chest. Well, yeah, I mean, I guess you could say, why does it have to say large? Because it probably is. It's chronic. It's not like they were just diagnosed as far as I could tell. Why not have they could very easily have a large barrel chest. It would still be right if it didn't say large, but I'm not going to overthink it and say I don't like the word large. It's okay. I'm okay with that word. So the only one that's unexpected is 2, respiratory rate of 8 breaths per minute. I definitely would not expect that for a patient with emphysema. So I'm going to pick that as the answer that I'm most concerned about.
Hey everybody, it's Tony Robbins. Listen, I've spent the last 43 years now working with people all over the world in 100 countries to show them how they can improve their lives. I've been obsessed with this question of what makes the difference in the quality of people's lives. Why is it so many...
Client who's been infected with the Ebola virus has an emesis of 750 mils of bloody fluid and complains of headache, nausea, and severe lightheadedness. Which action included in the treatment protocol should the nurse take first? Give acetaminophen, administer ondansetron, infuse normal saline, or increase the oxygen flow rate to 6 liters per minute. All right, so here I have a patient with a diagnosis and symptoms. One patient with a diagnosis and symptoms. And then it says, what am I going to do first? So now I'm saying to myself, well, which is the physiological finding? Because I have to address the objective physiological finding first, and then I can address everything else. So let's see if there's any objective physiological issues. Okay, Ebola virus certainly is an objective finding. Emesis of 750 mils of bloody fluid. Well, that's measurable, right? I just measured 750 mils. So that's certainly objective, physiological. So that's at the top of my list. Complains of headache. Well, that's subjective, right? That's just a subjective complaint. So that's comfort. Nausea, that's a complaint. That's subjective. Severe lightheadedness, that's what they're complaining of. So that's all subjective, which action included in the treatment protocol. So I have to address the 750 mils of bloody fluid first. That's what I have to address. So they just lost 750 mils. So let's see if there's an order that addresses the fact that they just lost 750 mils. Give acetaminophen. Well, that's for the headache. So no. Administer ondansetron. Well, that's for the nausea. So no. Infuse normal saline at 500 mils an hour. Well, that's addressing the fact that they just lost 750 mils. Increase oxygen flow rate. I don't even have any oxygenation symptoms here. So I don't want to get distracted by the oxygen because we always go, we got to do oxygen first. Well, not if there's no oxygenation issues. And you might say, well, there probably are oxygenation issues. Well, you're right, there probably are, but you can't use the word probably when you're testing, okay? You only go with what you know, not what is probably true. Okay, so the only thing that addresses the objective problem is the saline. And you might say, well, Sharon, the ondansetron addresses the emesis. No, it doesn't. The ondansetron addresses the nausea. And you might say, well, why not give the ondansetron first so that they don't throw up again? Because this is not how you test. I mean, you can say in real life, I'd give the ondansetron first. Well, first of all, you wouldn't give the ondansetron first. Not after they just lost almost 1,000 mils of fluid. You would not give the ondansetron first. You'd be running around to get that fluid replaced is what you'd be doing. So first of all, you wouldn't give it first. Now, you may have a second nurse at the bedside who's giving the ondansetron while you're doing the fluid. That's fine. But I know you wouldn't give the ondansetron first, so don't tell me that's what you would do. The nurse is caring for a newly admitted client with increasing dyspnea, hypoxia, and dehydration who has possible avian influenza. Which of these prescribed actions will the nurse implement first? All right, so here we have a patient with a possible diagnosis, avian influenza, and a bunch of symptoms, and they want to know what order we'd implement first. Start oxygen, infuse D5 water at 100 mils an hour, administer the first dose of oral oseltamivir, obtain blood and sputum specimens for testing. All right, so we have to figure out which is the physiological objective problem, and then we have to address that first. Dyspnea. Do you know dyspnea is subjective? That's the patient reporting their dyspneic. So that's subjective, that's comfort. Hypoxia. Well, that's actually objective. You can't say somebody's hypoxic, if you don't have an O2 sat to back that up. So it's for me to say they have a low O2 sat is not assuming anything. That's what the word hypoxia means. So hypoxia is objective. Dehydration. Well, dehydration is also objective. I can't say they're dehydrated if I don't have evidence for it. So that's by definition, that's objective. Possible avian influenza. Okay, fine. Which of these prescribed actions will the nurse implement first? All right, so start oxygen. What does that address? Well, that addresses the hypoxia. All right, I like it. Infuse D5 water. Well, it's the wrong solution, but if it was the right solution, it would be addressing the dehydration. Administer the first dose of oral oseltamivir or obtain blood and sputum specimens. Now, so we're going to cross off the blood and sputum specimens because that's not addressing any of the issues. And you might say, well, why wouldn't we administer the first dose of oral oseltamivir? Because, well, first of all, it's possible avian influenza. And second of all, we have a clear, objective, high-priority problem that we have to address first, and that's the hypoxia. So we have to do that before we do anything else because that is the clear, objective physiological problem. So if I use my ABCs to prioritize between physiological problems. If I have two physiological problems, I go, well, which one do I do first? Well, I use my ABCs, so I'm going to do oxygen. However, I would never use D5 water to rehydrate. I would only ever use normal saline to rehydrate. So I wouldn't pick two anyway. Now, just to give you a heads up here, sometimes you'll have two physiological problems and neither one of them are ABC. And then you go, well, which one do I prioritize then? So let's say you had diarrhea and malnutrition. Those were your two problems, both physiological, objective, diarrhea, malnutrition. But neither one of them are ABC. So then I say, well, which one's acute over chronic? So I go with acute over chronic. And diarrhea is acute, malnutrition is chronic. By definition, you don't become malnourished overnight. So I'm going to have to go and treat the diarrhea first.
Then what about the moment when you actually realize that you're not here by accident? That there is a God that really loves you so much that sent his son on a rescue mission for you.
This is something special.
We're gonna do this.
On the other side of temporary pain, you meet your other self.
God is setting you up to be blown away.
An 88-year-old client who has not yet had the influenza vaccine is admitted after reporting symptoms of generalized muscle aching, cough, and runny nose starting about 24 hours previously. Which of these prescribed meds is most important for the nurse to administer at this time? So I have one patient with a possible diagnosis. They don't say it, and I don't love that they don't say it, except they make it pretty clear that this person probably has the flu. They say they didn't have the vaccine and all their symptoms are the symptoms of the flu. So it's really pretty clear that they probably have the flu. So what are the orders? Oseltamivir, guaifenesin, acetaminophen, and influenza vaccine. Whenever you see a drug that has VIR at the end, that's an antiviral. And oseltamivir is Tamiflu. And so that's for the flu. So let's see. So they probably have the flu, and then the symptoms are what? Well, do you see it says admitted after reporting symptoms? That means every single one of the following things are subjective. Muscle aching, cough, and runny nose, all subjective. And you could say, well, cough is objective. Well, it's not when they say they reported it. If they say you observed them coughing, that's objective. If it says they reported a cough, that's subjective. So all of these are subjective findings. So oseltamivir is for the flu, guaifenesin is for the cough, maybe a little for the runny nose. Acetaminophen is for the general muscle aching, and the influenza vaccine. Well, I'm going to cross off influenza vaccine because there's no point in giving it right now. We can give it later if we want, but there's no point in giving it now. And 2 and 3 are for the subjective findings. The oseltamivir is for the flu, and because they make it very, very clear that they have the flu here, even though they don't say they have the flu, they make it really clear they probably do, then I'm going to go ahead and give that because having the flu is an objective problem. And you have to give Tamiflu or oseltamivir. You have to give it early or it doesn't do any good. So I'm going to go ahead and give that first. Because all the other symptoms are subjective, I can go ahead and give the oseltamivir first. Now I wanted to show you the difference between this question and the previous question, because the previous question also had number 3, administer the first dose of oseltamivir. Why didn't we pick it then? Because we have a clear physiological, objective, measurable problem. And when we have a clear physiological, high concern problem like hypoxia, we have to address that first. We cannot say, oh, we're going to let him be hypoxic while we give him the oseltamivir. No, 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 no. Don't say that, okay? But I wanted to show you that the right answer is the right answer because of the other answers. Mark has said this. If you watch the interview with Mark that's on our homepage, he says, don't ever memorize answers from question banks because the right answer is only the right answer because of the other answers. And this demonstrates that. Both people have the flu, but here, one time we prioritize oseltamivir and the other time we don't. So do not memorize that oseltamivir or Tamiflu is always the priority for a patient with the flu because it's not. It depends on the other symptoms and the other answers. During the initial post-op assessment of a client who has just been transferred to the post-anesthesia care unit after repair of an aortic aneurysm, the nurse obtains these data. Which finding has the most immediate implications for the client's care? All right, here we have one patient and all we know is their diagnosis. We don't have any symptoms, no signs and symptoms of anything. So that means we got to pick the unexpected finding. Well, what's the diagnosis? The diagnosis is they just returned to the PACU after aneurysm repair. And pay attention to the just been transferred to the PACU. That's a key word, just returned. So let's read the answers. A line indicates blood pressure of 190 over 112. Cardiac monitor shows frequent PACs. There's no response to verbal stimulation. Urine output is 40 mils. All right, so I'm going to turn this into a series of true-false questions because I'm looking for the unexpected finding. So for a patient who has just transferred to the PACU after aortic aneurysm repair, I would expect their blood pressure to be 190 over 112. All right, don't ever say true to that. We never expect our patients' blood pressures to be 190 over 112, unless they tell me they were admitted in hypertensive crisis. Other than that, I don't ever expect their blood pressure to be high. So 1 is false. I don't expect that. For a patient just returned to the PACU after abdominal aneurysm repair, I would expect their monitor to show PACs. I don't know. I mean, maybe. I mean, as an experienced nurse, I say, well, actually, I wouldn't be that surprised because there's a lot of reasons why they could have PACs. But let's say I'm a novice, okay? If I'm a novice, I'm going to go, I don't know, maybe. I don't know. So don't be afraid to put a question mark next to it. Maybe, right? Question mark, okay? So we'll leave that on our list. 3, for a patient who just returned to the PACU after major surgery, I would expect there to be no response to verbal stimulation. Absolutely true. I mean, that's why they're in PACU, right? Because we're recovering from anesthesia. So of course they're not going to respond to verbal stimulation. So that's fine. For a patient who just returned to PACU after major surgery, I would expect the urine output to be 40 mils of amber urine. Yeah, that's fine. I mean, they just returned. They don't give me a time frame, so I can't say it's low because I don't know how long it's been. So, I mean, I have to say, sure, that's fine. So I'm going to cross off 3 and 4. So now I have to decide between 1 and 2. Well, which one is more unexpected? That they have PACs, which are not particularly dangerous dysrhythmias, or that they have a very high blood pressure? Which one am I more concerned about? Well, 1 is really the circulation issue, right? Because when you have really high pressures like that, that can affect circulation, and ABCs, that's circulation, right? PACs don't really affect circulation. You still have good cardiac output with PACs, so that doesn't affect anything. So I have to be most concerned about the blood pressure of 190 over 112.
When your kid is hurting and there's nothing you can do about it, that's the worst feeling in the world.
I don't think anybody ever expects to hear that their child has cancer. It's always one of those things that happens to somebody else, but it's definitely feels like your soul is sucked out of your body when they tell you that it's your baby. And you would do anything to get them to the best place that they can be for their treatment. And I knew with everything in my soul that that was St. Jude and that we had to get here. Everything about cancer is already so hard. I can't imagine how people do this without St. Jude.
My name is Hunter. I'm at St. Jude because I had osteosarcoma. Osteosarcoma is a special cancer that's in the bone, so they had to amputate my leg.
You're looking at a hero. It takes a fighter. Good catch. You're looking at a hero in the fight.
My hero.
Here at St. Jude, you don't ever have to worry about how much treatment costs. You never get a bill, ever, for any of it.
1 in 5 children diagnosed with cancer in the U.S. will not survive. St. Jude gives kids with cancer the chance they deserve. Help St. Jude give every child with cancer a chance.
Without the donors, St. Jude wouldn't be here.
Thank you so much. You have saved so many kids.
Let's cure childhood cancer together.
A patient with chemotherapy-related neutropenia is receiving filgrastim injections. Which finding by the nurse is most important to report to the healthcare provider? All right, so I have one patient, and all I know is their diagnosis. and that they're receiving a medication for that diagnosis. All right, the patient says my bones are aching. The patient's platelet count is 110,000. The patient's white count is 39,000. The patient reports that the medication stings when it's injected. All right, let's look at this. So what is the diagnosis? The diagnosis is neutropenia, and that's all we know. So we have to consider which finding is unexpected. All right, if you don't know this, neutropenia means low white count. You got to know that. Neutropenia means low white count. Now, there's two other words for it that you should know. Neutropenia also means low white count. Sorry, my handwriting's bad. And agranulocytosis also means low white count. Okay, so those two words mean a low white count. You don't want to miss the question because you don't know what the words mean. Mark always says, as long as I've known him, poor vocabulary is the #1 reason people fail NCLEX. So you got to know the vocabulary. All right, so they're getting, it's chemotherapy-related low white count. All right, I get that. They're receiving filgrastim injections. So I'm going to assume, in this case, it's okay to assume that filgrastim is to increase white count. I mean, even though I've never heard of filgrastim, I say, well, it makes sense that that's to increase white count, okay? So I'm going to, and that's all I know. I don't have any symptoms. So which symptom, I don't have any symptoms in the question. So this isn't a physiological versus comfort versus psych issue, right? This is a what is expected versus unexpected. So for a patient who has a low white count, who's receiving a medication to increase their white count, which finding is expected or unexpected? Really, which one is unexpected? So for a patient who's neutropenic receiving a med to increase white count, I would expect them to tell me their bones are aching. That just, my gut tells me that seems okay to me. I mean, what is neutropenia? And if you're trying to increase white count, where are those cells going to be generated? Well, they're going to be generated in the bone marrow. So that would just, my gut says that I should expect that. So I'm okay with that. For a patient who's neutropenic, low white count, who's receiving filgrastim, I would expect their platelets to be 110,000. All right, if you don't know this, normal platelets are 150,000 to 400,000, okay? So when we look at labs, like in clinical, only is going to say 150 to 400. So sometimes that throws us off a little bit when we see these big numbers. So just know that normal is 150,000 to 400,000, and we don't usually worry about it until it's under 90,000. But even if you don't know that, you go, well, okay, the platelets are low. I mean, that's a problem. I don't know if I would expect that. So it's okay to say, I don't know if I would expect that. So put a question mark. We're going to leave it on our list. We're crossing through #1, but we're going to keep 2 on our list. For a patient with low white count who's receiving a med to increase white count, I would expect their white count to be 39,000. Whoa. Okay, normal white count is 5 to 10, and some people might say 4 to 11, and that's 1,000, by the way. So whether you say 5 to 10 or 4 to 11, it doesn't really matter, because that ain't nowhere close to 39,000. I mean, think about this. Their white count was probably less than 4. They were neutropenic, right? So their white count was probably less than 4. Now we give them filgrastim, and all of a sudden their white count is 39,000. It's 3 times what it's supposed to be, and probably 4 or 5 times what it was. Yikes, is that really expected? I don't think so. Okay, so we're going to definitely keep that on our list. So for a patient who's neutropenic, who's getting a drug to treat that, I would expect them to report that the medication stings when it's injected. Well, it is injected, and I don't know of any drug that doesn't sting when it's injected, so I'm going to say that's expected. So I'm going to cross that off. So now I have to say, well, which is more unexpected? That they have a slightly low platelets, or that they have a white count that's 4 times what it's supposed to be, and probably 5 or 6 times what it was to begin with? I think I'm a lot more concerned about that really, really, really high white count. I'm thinking that's what I'm really concerned about. So that's the one. That's the unexpected one. That's the one I'm going to go with. Well, thank you for coming along for another ride with me, and I wish you all the best on NCLEX if you're taking it soon. And if you've got a little time to study, then make sure you go through some of our other videos, and I'll keep coming out with videos. Welcome to the Clinic Review family. Check out all of our reviews and where they're at clinicreviews.com. And I wish you all the best. See you later. Have a great day.
The truth is, not every child gets the chance to go to the movies. In North America alone, more than 20 million kids may never step inside a theater. But together, we can change that. I'm Phil Cunningham, creator of David. Our goal is to help 1 million kids experience David.
Hello, Clinic Review family. I think you're going to like the video today. We're going to be doing respiratory prioritization. So we're going to be looking at best and first questions. A lot of first questions. I haven't done a lot of those before. And I'm also going to be using common sense in this as well. Okay, first let me say thank you to all of our channel members. And if you are interested in paying me for something, you can go to clinicreview.com and sign up for my next gen small group tutoring. You do have to pay for that, and you can also at the same time or instead of, you can sign up for Mark Klimek's small group tutoring, or you can sign up for the Klimek Online On-Demand Review, which is the best NCLEX review in the universe, in my opinion. So let's go ahead and get started with our respiratory prioritization questions. The nurse is caring for a client who has had a lobectomy and placement of a chest tube 8 hours ago. When performing an initial assessment, which of this requires immediate follow-up? 200 mils red drainage from the chest tube over 2 hours. Client sleepy but able to be aroused. 3 centimeters area of red drainage on the incisional dressing. Report of pain at the chest tube insertion site. So read the question, read the answers again, read the question again. The nurse is caring for a client who has had a lobectomy and placement of a chest tube 8 hours ago. When performing an initial assessment, which of these requires immediate follow-up? So it's the initial assessment. That's a key word, y'all. This is the initial assessment and immediate follow-up. Those are the key words. So anything that says which would require immediate follow-up, or which would you be most concerned about, or which would you call the doctor about, all those mean the same thing. Whenever you see that word requires immediate follow-up, you say which of these is unexpected. Okay? Which of these is unexpected? That's why the initial assessment is key, because which is unexpected at the initial assessment after someone who just had part of their lung removed and a chest tube placed, okay? So you say to yourself, 200 mils of red drainage from the chest tube over 2 hours. Is that expected or unexpected? Well, they did just have surgery, so you would expect there to be some drainage. But I don't know that I would expect 200 mils of red drainage over 2 hours. I might expect serosanguinous drainage. They did have surgery, so there's going to be some blood in there. So I would expect some serosanguinous, maybe even some more pink, that's serosanguinous. But 200 mils of red drainage, I'm concerned about that, because this is my initial assessment and they just had surgery. So I'm wondering if they're bleeding somewhere. And the key word in that answer is red. If it said serosanguinous, I would not be as concerned about it. B, client sleepy but able to be aroused. Well, they just had surgery. This is my initial assessment. So that's expected. 3 centimeters area of red drainage on the incisional dressing. So 3 centimeters of red drainage. Well, that's not unexpected. They just had surgery. They may have leaked out a little bit. Some of the blood might have leaked out onto the post-op dressing. So I do want to keep my eye on it, make sure it doesn't get more. There's not more, but immediate follow-up is not what's required. It requires some sustained follow-up, but not immediate follow-up. Report of pain at the chest tube insertion site. Well, that's expected. Do I want to do something about it? Yes, but it doesn't require immediate follow-up. You got to understand the words in these questions. Immediate follow-up means this is unexpected. That's what that word means. So the only one here that's unexpected, because I expect pain, I expect him to be sleepy, I expect there to be some drainage on the post-op dressing, but I don't expect there to be 200 mils of red drainage from the chest tube over 2 hours. That's a lot. It's red. It could indicate bleeding. They just had surgery, and this is my initial assessment. So A is the correct answer. And this is a prioritization question because it's asking you what is unexpected. What is the one that is your highest priority? What's the immediate follow-up? Which one requires you to call the doctor? Okay, question 2. A client has just been admitted to the ICU after having a left lower lobectomy via video-assisted thoracoscopic surgery. Which of these prescriptions will the nurse implement first?
Smile Zemi. The Smile Zemi tablet offers a home learning method that encourages independent learning and fosters confidence, leading them to a future full of smiles. This unique learning cycle encourages independent.
Titrate oxygen flow rate to keep O2 sat at or greater than 93%. Administer 2 grams of cefazolin IV now. Give morphine sulfate 4 to 6 milligrams IV for pain, or transfuse 1 unit of packed red blood cells over 2 hours. All right, a client has just been admitted to the ICU after having a left lower lobectomy via video-assisted thoracoscopic surgery. Which of these prescriptions will the nurse implement first? So here they give you a patient, and then they ask you which prescription, or it could say which order will you implement first. Whenever they ask you this question, they say, here's what's going on with the patient. Which order or prescription do you implement first? You always prioritize according to Maslow. And for clinic reviews, we talk modified Maslow. So the highest priority are objective physiological problems. Second is safety. And third is comfort. So we have to identify, according to the order, what does it address? So A addresses hypoxia. Hypoxia, titrate the oxygen to greater than 93%. That addresses hypoxia. Hypoxia is an objective physiological problem. 2 grams of cefazolin IV now. That addresses a potential infection. There's no actual infection. There shouldn't be. There's no actual infection. It's to prevent potential infection. And so at this point, I want to address actual problems, not potential problems first. So I'm going to cross off B for now. Give morphine sulfate 4 to 6 milligrams IV for pain. Well, pain is comfort. It's subjective, right? Anything subjective is comfort. So I already have a physiological objective finding in A, so I'm going to cross off C for now. Transfuse 1 unit of packed red blood cells over 2 hours. So that may be, let's say they're anemic. It doesn't tell us they're anemic, but let's say they are. That's why it's given. It's given for anemia. So we have 2 objective problems. We have hypoxemia or hypoxia in A, and we have anemia in D. Even though they didn't tell us those were their problems, that's why you do those 2 interventions. So would it be a higher priority to address hypoxia or anemia? And in this case, we're going to go with the ABCs, and we're going to say airway, breathing, and then circulation. So we're going to go with airway, breathing first, which is A. Circulation would be D. Making sure they're perfusing with enough red blood cells, that would be D. So we're going to go with A as our top priority. I do have prioritization videos they are labeled as prioritization videos where I teach these 2 strategies. Okay, I teach both of the strategies, the one I did in question 1 and the one I did in question 2. I teach the strategies themselves. 3, the change of shift report has just been completed on the med-surg unit. Which client will the oncoming nurse plan to assess first? So this is not what are you most concerned about. This is not which order will you implement first. This is which patient you will see first. So when you have 4 patients, you see the unstable patient first. So let's read through this and see who's unstable. Client with COPD who is ready for discharge but is unable to afford prescribed medications. Well, if they're ready for discharge, y'all, they are stable. Otherwise, they wouldn't be going home. So we're going to cross off A for now. We can come back to it if none of the other patients are unstable. But right now, we're going to cross it off because they're clearly stable. Client with cystic fibrosis who has an elevated temperature and a respiratory rate of 38 breaths per minute. Well, they're unstable. That's a very high respiratory rate. The temp is up. I'm concerned if they have some immune issues going on or an infection in addition to cystic fibrosis. I'm concerned about that. And don't say, well, 38 breaths per minute is expected with cystic fibrosis. It is not expected with cystic fibrosis. That is an unexpected finding. I don't care their diagnosis is cystic fibrosis. I don't expect their respiratory rate to be 38. So B is unstable. So I'm keeping there on my list. A hospice client with end-stage pulmonary fibrosis and an oxygen saturation of 89%. So I would say they were unstable except their hospice. And hospice patients are, they can be unstable and we don't do anything about it. That's why they're in hospice. So even though C is unstable, because they're hospice, I'm not going to prioritize them. D, client with lung cancer who needs an IV antibiotic administered before going to surgery. So that's, I mean, we need to get that going, but they're not unstable. And we always see the unstable patient first. So don't say to yourself, well, I could just give them their antibiotic really quick and then they'll go to surgery and then I'll go see B. No, that's not how you answer these questions. You see the unstable patient first. So B is unstable, and that's who we're going to see first. All right, question 4. A client with acute exacerbation of asthma has been admitted to the medical surgical unit for treatment. The client is reporting increased shortness of breath with inspiratory and expiratory wheezes. When planning care for this client, which medication will the nurse administer first? So this is, I mean, it's a first question, so it is a prioritization question, but this one is one you just have to know. You either know it or you don't. Beta.
Here's something most drivers don't know. The older your car, the cheaper your insurance should be. If your vehicle was made before 2022, you could qualify for full coverage at a steep discount, sometimes as much as 81% off.
Two agonists, they're the ones that open up the airways. So short-acting and long-acting beta-2 agonists, they end in EROL, erol. Salmeterol and albuterol are the two beta-2 agonists that open up the airways. Ipratropium is not a rescue medication, and fluticasone is a steroid. Usone drugs and insone, that's a steroid. It's not a rescue medication. So we're going to choose between C and D. So salmeterol, they end in erol. It's a beta-2 agonist. So salmeterol is the long-acting one. Albuterol is the short-acting one. It doesn't matter that it has a 2 after the end of it. Don't let that throw you off. The correct answer is albuterol. Y'all, you got to know that. That's very fundamental nursing knowledge. Albuterol is always the rescue medication, and this person needs rescue, right? It's an acute exacerbation. You know it, it's rescue medication because it's an acute exacerbation. So we need to do the rescue med. All right, 5. When caring for the client with chronic bronchitis, which of these interventions will assist the client in mobilizing secretions? Which of these interventions will assist the client in mobilizing secretions? Elevate the head of the bed 45 degrees, consume at least 2 liters of fluid daily, avoid triggers which cause coughing, or assume the tripod position. Okay, let's read it again. When caring for the client with chronic bronchitis, so that's the problem, which of these interventions will help assist the client in mobilizing secretions? So it doesn't sound like a prioritization question, but it is. It's a best nursing action question. Best nursing action questions are prioritization. So which of these will, it doesn't say best assist the client, but that's what it means, is which will best assist the client mobilizing secretions. So what we have to do is relate each one back to mobilizing secretions. Don't relate it back to just general respiratory. Which one is helpful in mobilizing? So elevate the head of the bed 45 degrees will help in mobilizing secretions. Well, I suppose would sitting up help mobilize secretions? I mean, I don't know. That's not, in my experience, that's not specifically helpful for mobilizing secretions. It helps to expand your lungs more, but it's not specific to mobilizing secretions. So I'm going to cross off A for now. I'll come back to it if none of the other answers make sense. Consume at least 2 liters of fluid daily. Well, if I can thin out the secretions, I know it helps in coughing that up or mobilizing them. So B is a good option. I like B. And don't be afraid of 2 liters, y'all. The recommended fluid intake for a person on a daily basis is 2 to 3 liters daily. So don't be afraid of 2 liters. Don't even be afraid of 3 liters unless they're fluid volume overloaded. Okay, if they're fluid volume overloaded, we're not going to go up to 3 liters. But for a healthy adult with not healthy, but an adult with functioning kidneys, we don't need to be afraid of 2 to 3 liters. So I like B. Avoid triggers which cause coughing. Well, that doesn't help mobilize secretions if I'm not coughing. I got to cough them up, so I don't like C. Assume the tripod position. So the tripod position is leaning forward. Will that help mobilize secretions? I mean, it might. Positioning, I mean, is better probably than other ways you can sit, but it's not a specific intervention for mobilizing secretions. So the only one that makes any sense is to consume 2 liters of fluid a day. And the only reason you wouldn't pick that is because you'd be scared of 2 liters. So you have to, don't be scared of that. Remember, 2 to 3 liters is the recommended fluid intake for an adult with functioning kidneys. Okay, so don't be afraid of that amount of fluids. All right, question 6. The client says, I hate this stupid COPD. What is the best response by the nurse? All right, so this is a question that really is a psych question wrapped in a med-surg setting. So he's saying, I hate something, or someone's expressing anxiety. I'm scared. I hate this. I don't know what to do about this. These are all psych statements. And so whenever the patient makes a statement and says, what's your best response? What it's really asking is what's most therapeutic. Now, you can only say that in a psych question. So don't say most therapeutic if it's a straight up med surg question, but this is a psych question wrapped in a med surg setting. So what we're really looking for is most therapeutic. And he's saying, I hate this. So what is a response to that? Stopping smoking will help your lungs heal. Well, that's not bad, but it doesn't really address his concern, right? He hates COPD. And so we're saying, well, if you stop smoking, you're going to get over COPD. Well, it will help his lungs heal to some degree, but it doesn't reverse COPD because the C in COPD stands for chronic. So if I say stopping smoking will help your lungs heal, it may help their lungs heal, but it's not going to reverse the COPD. So it's a very misleading statement. It's not absolutely false, but it's misleading. So A is misleading. I don't want to say something misleading. You sound fed up with managing your illness. Is that therapeutic? Well, it's reflecting back to them what you hear them saying. So they say, I hate COPD. And you go, okay, what does that really mean? That's kind of reflecting back to them. You sound fed up with managing your illness. That is a therapeutic interaction, right? There's therapeutic statements. I'm going to keep B on the list. Does anyone in your family have COPD? I don't know how that helps him. And it's a closed-ended question, which isn't therapeutic. So I'm crossing off C. Most clients get used to it after a few months. Well, that's a false statement. I can't imagine that's true. But even if it was true, it's not helping him out any. So the only one that's therapeutic here is to say you sound fed up with managing your illness. Reflection, clarification, that's appropriate to do. All right, question 7. The nurse is assessing a client admitted with status asthmaticus. So status asthmaticus is asthma attack that's not getting better, even though you'd kind of treat it.
Whoever invented this thing deserves a raise. I can't believe it's already 2025 and some people are still doing outdoor lighting like it's the Stone Age. Check this out. Solar light that keeps your whole yard lit without spending a single cent on electricity. Covers a huge area, perfect for the yard, garage, or anywhere you need light at night.
The nurse finds a sudden absence of wheezing in the lung fields and sets which of these as the priority action. Education to prevent future exacerbations, administration of a bronchodilator, measures to reduce anxiety, or activation of the rapid response team to secure an airway. So status asthmaticus is an asthma attack that's not getting better with treatment. So I'm thinking the fact that it's called status asthmaticus tells me that it's been going on a while. And my guess, although it doesn't say this, my guess is they already took an inhaler at home or they've already tried an inhaler, because if they haven't tried an inhaler, they can't call it status asthmaticus. Okay. Otherwise they just go, well, they're having an asthma attack. But if they're treating it and it doesn't get better, it's status asthmaticus. So all of a sudden they have an absence of wheezing. So they have asthma attack that's not getting better despite treatment. And then all of a sudden they have the wheezing they had is gone. That is actually a sign that their airways have closed off. It didn't say they now have lung sounds. That's not what it said. It doesn't say they now have lung sounds. It says they have an absence of wheezing. So what that means is you're not hearing anything is what it means. You're hearing nothing, okay? So if you're hearing nothing, if their airway has closed so much, you have to activate the rapid response team. So the key word in this question is the term status asthmaticus and absence of wheezing. Those two words combined, status asthmaticus and absence of wheezing, when you combine those words together, it tells you they're not getting any air into their lungs and you need to secure the airway. All right, question 8. When caring for the client returning from thoracotomy and placement of a chest tube, the client reports severe pain. What does the nurse do first? Okay, so, all right, so they've got a chest tube and they're saying, I just had this procedure and now I have a chest tube and I'm having really severe pain. Oh man, it's really killing me. Okay. All right. What am I going to do? Assess location and quality of the pain, call the rapid response team, check the patency of the chest tubes, or call the healthcare provider. So what do I do first? Okay, first. All right. So I like A. I'm not ready to do B first because they're having severe pain, but I don't have enough information to call rapid response. Okay, I don't know anything except they're having severe pain. So I just don't know enough. So I like A. I'm not ready to do B yet. I like C. And D to me is not first. This is a first question. So I'm calling off, I'm crossing off B and D as not first. Pretty confident those are not first. So the question is, do I want to assess the location quality of pain before I check the patency of the chest tubes, or do I want to check the patency of the chest tubes before I assess location quality of pain? So they're both sort of assessment options, but I would rather know where the location quality of pain is, because if it's not at the chest tube site, maybe it's somewhere else, right? I don't even know where it's at. So why would I check the patency of the chest tubes until I at least know where the pain is and when it's occurring? Is it occurring with the deep breath? Is it occurring all the time? Is it at the chest tube site? Is it at the different incision site? Like, where is this, right? So I have to do A first. Otherwise, I don't really know what to do after that. I've had a lot of people say, well, you always assess first. Y'all, you don't always assess first. If you have enough data to do something, then you do something. But if you don't have enough data to do something, then yes, you have to assess first. And here we don't have enough data to do anything. So yes, we do have to assess first. Okay, question 9. The nurse is evaluating and assessing a patient with a diagnosis of chronic emphysema. The patient is receiving oxygen at 5 liters per minute by nasal cannula. Which finding concerns the nurse immediately? Find by basilar crackles, respiratory rate of 8 breaths per minute, the patient sitting up and leaning over the nightstand, or a large barreled chest. All right, the nurse is evaluating and assessing a patient with diagnosis of chronic emphysema. So they've got emphysema, it's chronic. They're getting oxygen, which finding concerns the nurse immediately. So this is the same question where it says, which would require immediate follow-up? When you see the word immediately, whether it says you see a UAP doing something which would require you to intervene immediately, when you see the word immediately in the question, that tells you there's something really wrong here, really unexpected. It's not the right thing, okay? So this is a patient with emphysema who's got oxygen going to 5 liters a minute. So which am I most concerned about? Well, I'm concerned about the unexpected finding. So what I expect someone with chronic emphysema to have find by basilar crackles. Maybe. I mean, maybe yeah, I guess so. I'm more used to hearing wheezes. I'm not crazy about crackles. I'm going to keep that on the list in case something else is not more unexpected. Respiratory rate of 8 breaths per minute. Well, that's super unexpected. I don't expect someone with chronic emphysema to have a respiratory rate of 8 breaths per minute. That's definitely more unexpected than A for sure. So I'm crossing off A. I'm going to keep B. The patient sitting up and leaning over the nightstand. Well, that's expected with chronic emphysema. That's tripod position. They're sitting in tripod position. That's something we teach them. We say, well, if you're feeling short of breath, sit in tripod position. So, okay, so C is expected. D, a large barrel chest. Well, they have chronic emphysema, so that's expected. So the only one that's not expected is a respiratory rate of 8 breaths per minute.
Check this out. I'm going to show you how I afforded this car. Okay, you ready? All right, $118 for car insurance. That's how much I was paying, okay? I picked up the car a few months ago, and watch this, ready? $97 premium, $20 were my fees, $118. Now, I covered up my private information, guys. $39, $118. Check this out, ready? $500 for comprehensive, $500 for collision, $500 for comprehensive, $500 for collision, okay? The same make and model, Hyundai Ioniq, okay? Guys, it's the same policy, $118 to $39. As you can see, I have full coverage. I have a premium policy. I love my coverage and I love my insurance company, but I was paying a lot and I didn't even realize it. Check this out. See, look. All right. Hyundai Ioniq. I picked my year, okay? Hyundai Ioniq. There's my make. I picked it already. And then you're going to scroll down and find your model. This Ioniq Limited. Guys, this only takes 2 minutes. Okay? Just, it's free. Stop overpaying. Fill this out.
All right, 10. Patient with chronic obstructive pulmonary disease, COPD, tells the UAP that he did not get his annual flu shot this year and has not had a pneumonia vaccination. Which vital sign change will be most important for the nurse to instruct the UAP to report? Okay, COPD, no flu shot, no pneumonia vaccine. Okay, what do we want to tell the UAP? They're taking their vital signs. We say, hey, if you see this, tell me. Blood pressure 152 over 84, respiratory rate of 27, heart rate of 92, or oral temp of 101.2. Okay, so I always want to have them report unexpected findings. So is a blood pressure of 152 over 84 unexpected? Well, it doesn't say he has hypertension, but it's not that high. Okay, that's like stage 1 hypertension. So I'm not that concerned about that right off the bat. Now, if nothing else is more weird, then maybe that one. But a stage 1 hypertension, I usually don't say, you got to report it to me right away. Respiratory rate of 27. That's pretty high. I don't like a respiratory rate of 27. So I'm going to keep that on my list. Tell me if the respiratory rate gets that high. Heart rate of 92. That's within normal limits. So I'm crossing that off. Oral temp of 101.2. Okay, that's abnormal. So unexpected. So B and D to me are both, well, A, B, and D are all not expected, but A is not that concerning. So I'm crossing A off. So B and D. So am I more concerned in a patient with COPD who did not get their flu and pneumonia vaccine? Am I more concerned about a respiratory rate of 27 or an oral temp of 101.2? So based on the data that they gave me, I don't think this is an easy question, y'all, because I am concerned about a respiratory rate of 27. But based on the data that they gave me specifically, which was about not getting the flu and the pneumonia vaccine, I'm going to have to go with the oral temp of 101.2 because that indicates to me that they could be having the flu or it could be turning into pneumonia. Okay. All right. Well, I hope that helps you. You're going to see probably 30% of your NCLEX is going to be prioritization questions. I hope it helped you. The strategies I taught you here can be used for other questions. Any prioritization question over any topic. These are all strategies that can be used. No matter the topic, if it's a prioritization question, you can use these strategies. So I hope you have a great rest of your day. Thanks. Bye.
I don't know what to play. That's okay. This is just a random phrase.
Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. I think you're going to like this video again. This is cardiac prioritization and when to call a rapid response. So first, thank you to all of our channel members. I really appreciate it. We're almost up to 200 members, so that's very exciting. And if you want to pay me for something, you can go to clinicreviews.com and sign up for one of my next gen small group tutoring sessions. That does cost something. You can also at the same time or in addition, sign up for Mark Klimek small group tutoring or sign up for the best NCLEX review in the universe, Klimek Reviews. You can sign up for that as well there. All right, so let's get down to business here. Business. We gonna get down to business. All right. The nurse is caring for a client diagnosed with an anterior myocardial infarction 2 days ago. Upon assessment, the nurse identifies a systolic murmur at the apex. What should the nurse do first? Assess for changes in vital signs, draw an arterial blood gas, evaluate heart sounds with the client leaning forward, or obtain a 12-lead EKG. Okay, the nurse is caring for a client diagnosed with an MI, anterior MI. So I don't know what an anterior MI is. When you don't, I know what the word anterior means. I can guess what an anterior MI is, but I don't know anything specifically about it. And when I don't know anything specifically about it, about a word, then I ignore the word. So I'm going to ignore the word anterior because I don't know if it makes any difference. So I'm just going to say diagnosed with an MI 2 days ago. Upon assessment, the nurse identifies a systolic murmur at the apex. Again, I don't know the significance of a systolic murmur at the apex. So I'm just going to say that an MI 2 days ago, today they have a murmur. What should the nurse do first? Assess changes in vital signs. Yeah, that seems like a good idea. I'm going to keep that on the list. Draw an ABG. I don't see any reason to do that. There's no evidence that an ABG needs to be drawn. They didn't give me an O2 set. They didn't say they were short of breath or anything. So I'm crossing B off. Evaluate heart sounds with the client leaning forward. Maybe, I don't know. I don't know if that would make a difference. Obtain a 12-lead ECG. Well, we don't typically get ECGs for heart murmurs. Heart murmurs don't have anything to do with electrical activity. They have to do with the valves. It's a valve issue. So I'm going to cross off D. So I've crossed off B and D. So assess for changes in vital signs or evaluate heart sounds with the client leaning forward. So I don't know much, if anything, about an anterior MI, and I don't know if it makes a difference that a systolic murmur at the apex. So instead of trying to guess what the right answer is, I'm just going to go generally and say, in general, if I assess something abnormal or something newly different about the heart, I like to get a set of vital signs. So instead of picking the answer I'm not sure about, C is the answer I'm not sure about. I don't know if I should do that. I do know it's always good to assess for changes in vital signs. So I'm going to pick that answer. And that's the correct answer. And so I want y'all, you don't have to know everything. Listen to me. You don't have to know everything. If you don't know what an anterior MI is, ignore the word anterior and say it's an MI. If you don't know what a systolic murmur at the apex signifies, just say a heart murmur. In an MI 2 days ago, now they have a heart murmur. Hey, let's see if there's been any change in the vital signs. Could you get it wrong if you do it that way? You could, but you're much more likely to get it right if you do that. Do not spend your time trying to memorize every bit of minutia information, y'all. Learn how to answer questions. Just be generally knowledgeable about good general principles and you will pass NCLEX. Okay. 2, during the post-procedure check, the nurse notes that the puncture site at the groin has begun to steadily ooze blood. What should the nurse do first? So they did some kind of a procedure where they had to go in through the groin and now it's starting to ooze blood. So what should I do first? Okay, the key word here is first, which means I'm going to see more than one answer that I like. I got to figure out what to do first. Don gloves and apply pressure over the site. Well, when there's bleeding, I like to apply pressure. That's a good idea. So I'm going to keep that on the list. Observe and document the bleeding.
If your gut's wrecked, I guarantee your sex life is too. You can't perform with an upset stomach, and who can blame you? Poor nutrient absorption, toxins leaking into your bloodstream, inflammation, and don't even get me started on the gas and blood.
Maybe, but that's definitely not first, what I'm going to do first. So, because when you say observe and document the bleeding, that essentially means I'm not going to do anything at all. And I'm not prepared to do nothing after a procedure where they're oozing blood. So I'm going to cross off B, notify the healthcare provider, maybe. Prepare protamine sulfate for IV administration. Maybe, because protamine sulfate is the antidote for heparin. However, it doesn't say anything about heparin here. So since it doesn't say anything about heparin here, I'm going to cross off D. So do I want to don gloves and apply pressure and then notify the healthcare provider? Or do I want to notify the healthcare provider and then apply pressure? So I know the general principle is when there's bleeding, you apply pressure. And there's no reason, they're oozing blood. There's no reason to think that I would need to call the healthcare provider before I apply pressure. So I'm going to apply pressure over the site. Okay. Now I have a number of questions we're going to go over where the right answer could be call the healthcare provider. And sometimes the right answer is going to be call the healthcare provider, and sometimes it's not. Listen, the right answer is the right answer because of the other answers. Do you hear me? The right answer is the right answer because of the other answers. Don't memorize, oh, well, then I always apply pressure when it's oozing. Maybe. I mean, you'd always apply pressure, but it will always be first. Maybe, maybe not. It depends on what the other answers are, y'all. That's why you don't use NCLEX question databases to study for NCLEX, because you can't memorize facts using that unless you want to memorize all the rationale, and that's not a good strategy at all. The nurse is assessing a client who's had an MI. The nurse notes the cardiac rhythm on the monitor, this rhythm, okay, on the monitor. What should the nurse do first? All right, so it looks like they have sinus beats. The first beat is sinus, the second beat is sinus, the third beat is sinus, the fourth beat is sinus. The fifth beat looks like a PVC. 6 is sinus, 7th is sinus. We have one PVC in the midst of a sinus rhythm. And if you don't know what PVCs look like, go back and watch the ECG rhythm videos. I'm not going to teach that again here. You can always watch those videos. So I've got a PVC, one PVC. Should I notify? What should I do first? First, it's a first question, which means more than one thing I'm going to want to do. Which one do I first? Notify the healthcare provider, call the rapid response, assess the client for changes in the rhythm, or administer the lidocaine as prescribed. Okay. One PVC, y'all. One PVC. You don't get worked up about one PVC. Okay. There has to be 6 or more. This is an NCLEX rule. This is not a rule for your clinical. This is not a rule for your ICU you work in. You want to follow the policies wherever you work. But on the NCLEX, the rule is if there's 6 or more PVCs in a row or in a minute, you got to be more aggressive. But one PVC, no big deal. So I'm just going to assess the client for changes in the rhythm. Okay. That's what I'm going to do. In fact, I wouldn't even do any of the other things. I wouldn't even do them. That's the only one I would do. While caring for a client who has sustained an MI, the nurse notes 8 premature ventricular contractions in 1 minute on the cardiac monitor. What should the nurse do first? Increase the IV infusion rate from 125 to 150. Notify the healthcare provider. Increase the oxygen concentration from 2 liters to 4 liters, or administer the prescribed analgesic. All right, so they've had an MI, and now they have 8 PVCs in a minute. That's a lot. That's remember we said 6 or more. You need to be more aggressive. Well, what does more aggressive mean? Well, one of the things that it means is you call the healthcare provider. If there's 6 or more, I would call the healthcare provider. So I'm going to keep B on the list. That's definitely one of the things I would do. Now, does increasing the IV rate help with PVCs? Someone has had an MI. I have no reason to think increasing the infusion rate would help at this point because they don't tell me what their blood pressure is or anything like that. So I don't have any reason to think that would help. Increasing the oxygen from 2 to 4 liters. Well, if someone's having PVCs, it could be because they are hypoxic, but they don't tell me they're hypoxic. So I'm not sure about C. Maybe. I'm going to keep it on the list as a maybe. Administer prescribed analgesic. It says nothing about pain. So D, I'm leaving off the list. So I'm crossing off A and D. So do I want to increase oxygen because it could be they're hypoxic, or do I want to notify the healthcare provider? So the question is, when do I notify the healthcare provider? You notify the healthcare provider when none of the other options are reasonable for you to do. Okay. So if I knew they were hypoxic, if it said their O2 sat was 90% on 2 liters, I would do C first. You hear me? But it doesn't say that. And words matter, y'all. You only know what they tell you. So I don't know they're hypoxic. And since I don't know that, the only reasonable option is to notify the healthcare provider. All right, next question. The monitor tech informs the nurse that the client has started having PVCs every other beat. So that's more than 6 in a minute, or 6, right? It's every other beat. So that's a lot. What should the nurse do first? Activate rapid response, assess the client's orientation and vital signs, call the healthcare provider, or administer a bolus of lidocaine. Well, lidocaine is one of the treatments for PVCs, but it says, what would I do first? And I don't think I'm going to administer lidocaine first.
Want to teach your child maths but have no time? Balancing home, work, and teaching my kid was a real struggle for me. I tried tutoring, but it didn't seem to help my child's grades improve. I needed something that was fun, effective, and affordable. That's when I found SmileZemi. Their learning tablets are amazing. They guide your kid through math, ELA, and word study that's in sync with school standards. And the star rewards make learning feel like an exciting game to them. As for us parents, SmileZemi makes it so easy to track your child's progress through their detailed reports. My child's focused on her studies while I get my chores done. Plus, it's cost effective. No more hefty tutoring bills and no commute needed. SmileZemi is a game changer, so go check them out.
Activate rapid response. There's no reason to think that this person is unstable yet. They didn't tell me their blood pressure. They didn't tell me skin. They didn't tell me urine output. They didn't tell me level of consciousness. So it's too early to call activate rapid response. And at this point, I don't know enough to give lidocaine. So I either have to assess client's orientation and vital signs and then call the healthcare provider, or call the healthcare provider and then assess the client's orientation and vital signs. And because it's a first question, I want to assess client's orientation and vital signs, because if I call the doc, if I call the healthcare provider and say, hey, they're in bigeminy. Bigeminy is every other beat is a PVC. If I call the doc and say, hey, they're in bigeminy, do you know what they're going to say to me? Well, are they alert? What's their blood pressure? What's their oxygen saturation? What's their skin color? See, they're going to ask me all these questions. I go, I don't know. I didn't assess that. Right? So I do want to call the healthcare provider, definitely, but not first. First, I need to assess the client's orientation and vital signs. Remember, I told you the right answer is the right answer because of the other answers. And I just showed you how that applies. In the previous question, we did call the healthcare provider first because none of the other options were reasonable based on what we know. In this question, another option was reasonable based on what we know. So that's why we chose vital signs and orientation first. Okay, 6, which client is at greatest risk for coronary artery disease? All right, you may not think this is a prioritization question, but it really is, because it's the greatest risk. What, right? Who would you prioritize as being in the greatest risk? So whenever you get a risk question and you have to choose what person is at greatest risk, here's how you answer it. You count the number of risk factors for each person, and you choose the person who has the most risk factors as the greatest risk. Okay, so let's do that. A, 32-year-old, so 32-year-old female, so they're premenopausal, so that's not a risk factor. Mitral valve prolapse. I don't think mitral valve prolapse is a risk for coronary artery disease. Quit smoking 10 years ago. That's a long time ago, y'all. I'm not willing to say that they quit smoking 10 years ago as a risk factor. If it is, it's a very low risk factor. I'm thinking A is off the board. Maybe they have one risk factor, but that's pushing it a little bit. B, a 43-year-old male, right? A male is at risk. 43 is at a risk factor. Maybe it's not as high as some of the older ages, but at least they're male. Family history of coronary artery disease, that's a risk factor. So he has 2 and a cholesterol level of 158. I think it's supposed to be less than 180. 158 is not very high. So I'm going to say they have 2 risk factors. C, a 56-year-old male. So he's even older. So based on his age and he's a male, I would say he's at risk, but an HDL of 60. Now, HDL is the good, it's the good cholesterol, and HDL is highly protective against coronary artery disease, and his is 60. So I would almost say an HDL of 60 kind of gets rid of one of the other risk factors. Like, that's a positive thing. So I would probably say C, because of his HDL. I'd say his risk factors really went down because of that HDL. So I'm still going to say B is a higher risk than C. Remember, B has a total cholesterol of 158. C has an HDL, high density lipoprotein, of 60. HDL is a protective. LDL is the bad cholesterol. HDL is the good cholesterol. Okay, D, 65-year-old female, postmenopausal. Postmenopausal female is a risk factor. Who's obese, another risk factor. And an LDL, the bad cholesterol of 188. That's really high for an LDL. So D clearly has the most risk factors, because even B only has 2 and D has 3. So we're going to go with D. So when you get a question about who's the highest risk for a certain problem, count the number of risk factors and choose the person who has the most risk factors. Which symptoms should the nurse teach the client with unstable angina to report immediately to the healthcare provider? So reporting immediately, whenever you see the word immediately, it means it's something that needs to be addressed now, not next week. Okay. And so we address unexpected findings now. That's what we do. So we're looking for an unexpected finding. So what we say is, which of these are unexpected for a patient with unstable angina? All right. A change in the pattern of chest pain is expected or unexpected with unstable angina. So anytime there's a change in the pattern, a changing assessment is always unexpected, right? It's just considered unexpected. So a changing pattern, I mean, they're not being treated. They're just like living their life. So a changing assessment is always considered unexpected. So I don't like A. That's an unexpected finding. Pain during sexual activity was expected or unexpected with unstable angina. Well, that's expected because they're doing activity, right? So sexual activity is activity, and you'd expect to have pain with activity. So that's expected. Pain during an argument. Well, that's kind of putting out they're demanding some oxygen. They might be yelling. Their heart rate might go up. So I would expect some pain with an argument. Pain during or after physical activity. Well, that's definitely when I would expect to have angina. So B, C, and D are all expected, y'all. So we have to pick a change in the pattern of the chest pain.
Before I go on holiday, I always wrap my passport in foil and my cards in foil. If you didn't know, there's people going around stealing your identity and your money. It's so easy for them. They're walking around with card readers and they're tapping your pockets or your bags. That's why I don't travel without this passport holder. It's fully RFID protected, so it can block out any signal. It can hold all your cards, your phone and your passport, and you just zip it up and you're protected. Currently it's on a discount and it's selling out fast, so I've linked it below. Click the yellow basket.
If you are going to travel, I recommend you buy one. It protects your passport and your money very well. It is too easy for thieves to transfer your money with a card reader, so that's why I recommend you buy one before you go traveling. It is completely protected, so it blocks any signal. It can hold all your cards, your phone, and your passport, and you just pull it tight and you are protected. It is currently on sale at an amazing price. There is not much stock left and it will sell out at any time, so I linked it below. Please click on the yellow basket to buy it.
Are you researching dental implants?
There's a lot of dental offices that'll talk about doing their teeth in the day process. A lot of times what they mean is they'll do the surgery and give you some sort of teeth the next day, but those...
Okay. 8, a client has returned from having a balloon valvuloplasty for mitral stenosis, which finding requires immediate nursing action. Again, immediate nursing action means I have to do something now, not later. There is a low grade 1 intensity mitral regurgitation murmur. SpO2 is 94% on 2 liters. The client has become more somnolent. Urine output decreased from 40 mils per hour to 60 mils per hour to 40 mils per hour over the last hour. All right, which finding requires immediate nursing action? So immediate nursing action is an unexpected finding, just like which one requires calling the doctor immediately. Immediate nursing action is unexpected. So for someone, and I go, well, I don't know anything about a balloon valvuloplasty for mitral stenosis. I could probably sit here for 10 minutes, think about it, and maybe figure out what it is. I mean, a balloon procedure is opening up a balloon to open something up. So we did something to open up the valve for mitral stenosis, but I don't know anything about it. I don't know what the risk factors are, any of that, okay? But instead of looking up a balloon valvuloplasty and memorizing everything there is about it, I'm going to say, well, in general, what do I know is important after a cardiac procedure? What would be unexpected after a cardiac procedure? So would I expect grade 1 intensity mitral regurgitation? Well, if they had mitral stenosis, I'm not sure that I would be that surprised if they still had a low murmur, because mitral stenosis causes a murmur. So maybe they're still going to have a low grade 1 murmur. Maybe, I don't know, but it doesn't seem that big of a deal. SpO2 is 94%. Well, that's normal. So 93% above is normal. So I'm okay with B. The client has become more somnolent. Well, I don't expect them to become more somnolent. They may come back from this procedure, which, by the way, is not surgery. It's a procedure. So they should come back from a procedure mostly alert. They may be a little sleepy, but they should be mostly alert coming back from a procedure, and they become more somnolent. So that's not expected. Urine output decreased from 60 mils per hour to 40. Well, both of those are within normal limits. 30 mils per hour is within normal limits. 60 and 40 are both within normal limits. So D is not unexpected. It's expected. So B and D are out. Those are both unexpected findings. So would I be more concerned about hearing a low grade 1 murmur or that they become more somnolent? Definitely, if I were to say as a nurse, and I could use good nursing judgment and just plain common sense, y'all, if they become more somnolent, which means they're more sleepy, they're more difficult to arouse, I'm way more concerned about than I am about a low grade 1 murmur. So That's the correct answer. So again, what I'm telling you and showing you with this video is you don't have to memorize everything. You just have to use good nursing judgment and common sense and understand the words of the question so you can know how to read it correctly. 9, what measures should the nurse take that will be most helpful in preventing wound infection when changing a client's dressing after coronary artery bypass surgery? Wash hands before changing the dressing, clean the incisional area with an antiseptic, use prepackaged sterile dressings to cover the incision, place soil dressing in a hazardous waste container. What measure should the nurse take that will be most helpful? So it's a nursing action. They don't say action, but they say measure, but it's a nursing action. So what is the best nursing action to prevent wound infection? And here, you should expect to get this question. It may not be about coronary artery bypass, but you're going to get a question where it says, what is the best nursing action to prevent infection? And it could say, it could be any infection, y'all. It doesn't matter what infection it is, anything. And the same answer is going to be the same, because something can only be best nursing action if it's a fundamental principle. So what they're saying here is, what is the fundamental principle? So let's see what even makes sense. Washing hands before changing a dressing, was that prevent wound infection? Yes. Cleaning the incisional area with antiseptic, would that prevent wound infection? Yes. Using prepackaged sterile dressings to cover the incision, would that prevent wound infection? Yes. Placing soil dressing in a hazardous waste container, would that prevent wound infection? I don't see how that would prevent wound infection. So I'm crossing D off. Now, I would say C is unnecessary. We don't usually, I would expect this incision to be closed, like stapled or glued shut. So we don't have to use sterile dressings for closed incisions. So I'm going to cross C off. I mean, it would probably help prevent wound infection, but it's not necessary. So I'm going to cross C off because we don't usually use sterile dressings. So I have to decide between washing my hands or cleaning it with antiseptic. And I'm like, I would want to do both. You're right. I would too. So what you do, because it's a best nursing action, and best nursing actions are always fundamental principles. So I'm going to do one, but never do the other. So I would wash my hands, but never clean it with antiseptic. Now it means I can clean it with other things. Like I could clean it with soap and water. Soap and water is not antiseptic, but I would never clean it with an antiseptic. Or I would clean it with an antiseptic, but never wash my hands. Y'all, you don't want to tell the National Council of State Boards of Nursing you're never going to wash your hands, do you? Do you see how this is the right answer? Because it's a best nursing action, and best nursing action is a fundamental principle that you always have to do, no matter the whatever it is. If you're preventing infection, what's the number one way to prevent infection? Whether it's after surgery, whether it's just going from room to room, whether you've got a cold in the community, what's the number one way to prevent infection? Wash your hands. Don't forget about that.
Here's something most drivers don't know. The older your car, the cheaper your insurance should be. If your vehicle
The nurse is caring for a client who has become unresponsive. The blood pressure is 80/40, and the SpO2 is 90% on 50% face mask. What should the nurse do next? Begin chest compressions, call the rapid response team, remove the family from the room, ventilate the client with a bag mask device. All right, so their blood pressure is low and their SpO2 is 90% on a 50% face mask. So they're getting a ton of oxygen and still only 90%, although it's not like 75%. So that's good at least. What should the nurse do next? Begin chest compressions. Well, I'm crossing off begin chest compressions because they've got a blood pressure. So I'm going to cross that off. Call the rapid response team. Well, this person seems very unstable. So I'm definitely leaving that on the list. Remove the family from the room. Okay, that's no longer something we do. We used to do that 20 years ago. We don't do it anymore. So I'm crossing that off the list. Ventilate the client with a bag mask device. So they're only 90% on 50% face mask. But so I think ventilating the client with a bag mask device may be what I want to do. So I'm keeping that on the list. So do I want to call? So I crossed off A and C. So do I want to call the rapid response team and then ventilate the client? Or do I want to start ventilating the client and then call the rapid response team? All right. I am not, the reason you call a rapid response is because your patient is unstable and you're not sure where to go from there. That's why you call it, because they're unstable. I'm not sure what to do right now. I need people to come in and help make some of these decisions. So I'm not prepared to start to if I'm going to call rapid response, I don't want to start ventilating them first. I want rapid response to come and say, hey, let's start ventilating them. Maybe we need to intubate them, right? Well, let's get an ABG. Let's figure all this stuff out. So I'm going to call the rapid response team first. We may at some point have to start to ventilate them, but I'm calling the rapid response team first. So you call rapid response when your patient is unstable and you're not sure where to go with that. And you need to get some advice on what to do. Okay.